Well, welcome everybody to day 2 of the A&T lectures. And I have 2 pages of notes after Al's presentation. I got 5 questions I need to ask him later as well. So I hope you've enjoyed that. For the next 2 hours, I'm going to be talking about how do we increase our value by expanding our support. And that's a different title than my first draft title for this, because I talked about stakeholders, and that's a big fancy word. What does that mean? But how do we get outside of our sphere of influence, respiratory therapists, our career in particular, to get others? Then I'll be talking about how we need to lead, whether you're at the bedside, you're an educator, an RT navigator, et cetera. And I think it's a nice segue into that question that was asked about what is the advanced practice. So with that, I'm going to stop my video so you can look at my slides and not me. So this presentation is expanding our value, and I'll talk about what value means. And how do we do that? Not alone, but working with others. As I mentioned yesterday, here are my disclosures. They haven't changed since yesterday. My proudest disclosure, AERC member since 1974, my student days, 1976 as a staff therapist. My disclosures, I want to announce that the proceeds from my honorarium will be provided to these charities. And what I've always thought about is how do we help people in need? Here are some easy ways to do that. So thanks to everyone on this presentation for providing that opportunity for me to give to others. So what are the components? These are my opinion based upon books I read, articles I've read, folks that I've talked to, administrators, physicians, nurses, and respiratory therapists. And if you heard me talk previously, I like lists. Lists help me remember, help me categorize, help me think about the sequence of making the case to get approval for a clinical ladder or for a change or for a new device. So I'm going to talk about these individually: the why, the what, the who, and the how. In my reading, in fact, our past AERC president, Karen Schell, said we always need to start with a why. Why are we having this discussion? Why do we need this? Why should we do it differently? And if the answer is things are just hunky-dory, that's a Pennsylvania Dutch word, if things are just hunky-dory and everything's firing on all cylinders and everything's rosy, we don't have to change. I'll suggest that's not the world that I grew up in as a respiratory therapist, and maybe even less so because of the challenges of the pandemic. So here's some examples. We can't go it alone because we don't have all the resources. I think last time I saw there's 190,000 respiratory therapists who in practice who have a license. There are 3.5 or so RN, 3.5 million RN. So right there, stop and think. Any opportunity that I could collaborate with a nurse gives us a lot more visibility. Strength in numbers, collaboration for the future. If you want to secure a publication for your article or abstract, and 99% of us are not going to do that, but there's other ways of publication within your department. I'll give you some examples. Communication or messaging, and ultimately to advance the visibility and value. The first part of value is you have to be seen at the table. And someone, I don't remember the source, said, if you're not at the table, you're on the menu. And when the Joint Commission comes or your boss comes to say, hey, who could do this? I would always like to see respiratory therapists get to the front of the line. So what are some of the resources we would have? Performance improvement department, quality assurance, if you call it data analytics in your organization. Strength in numbers, I mentioned nurses, certainly physicians. They have a greater visibility and greater value in an organization because of their knowledge, their skill set. What about collaboration? Not only establishing relationships today, let's say it's an RN-RT rapid response team or an RN-RT wean team, but the value for future collaboration. So working together with another professional today will help you in the future. They may come to you and say, hey, we worked together a couple of years ago on this project, worked out pretty cool. I got something, and we were thinking, who are we missing? Respiratory therapy. Would you want to join our team? Now, publications, I'm going to start. Most of us aren't going to publish in respiratory care or JAMA or ATS, but having a quality assurance project, you can publicize that within your department. It may be a simple one-page document that gets thumbtacked to the bulletin board. Here's what this team did to improve process X. The second, and keep this date in mind, if it is like last year's, it should be June 1st, 2023. If you've done a quality assurance project or a performance improvement project, you should submit to the AERC as an abstract. If selected, that gets published in Respiratory Care Journal, usually in the October special edition. Thirdly, if you have that abstract and it maybe doesn't have all the data points, not enough metrics, you can use that to build on an official paper and then submit that to publication. So what about communication and methodology? I don't know about you, but I've had it with Zoom, not the present presentations today, by the way, and Teams and email and Twitter and Instagram. Yes, we actually have to use all of that. Some of you, in fact, maybe a lot of you heard about these programs via A&T lectures, publications on Facebook or Twitter or Instagram or email group from colleagues. Certainly that is essential. I'm going to suggest that while that is useful, we need to make sure when it's appropriate for face-to-face presentations that we do that. And let me give you an example. Here's a group, a multidisciplinary group, about 8 or 9 folks, and they did a fantastic job in their COPD pathway. Had they merely sent out the Excel spreadsheet of how they impacted readmission rate, patient satisfaction, cost, et cetera, to the executive team, how many of you think would have read that and recognized how big a deal this was? This was a 6-figure savings, greater patient and family satisfaction. The staff involved felt better about themselves. So I would ask you to think about the mode of communication. And in my world, never neglect the power of face-to-face communication. The team presenting to the Med Exec Committee or to the Nursing Council or maybe a Respiratory Council if you work in a multi-hospital system. Just think about that. Also, excuse me, my allergies are still here today from yesterday, not worse. So I pardon that. Some hospitals still have an internal paper newsletter. It might be electronic, certainly get your work in there, but if it's paper, make sure that you can go around and post out in all the court bulletin boards if you still have those things in your hospital. So those are some examples of the why. So what are the areas of performance? In one of my presentations yesterday, I mentioned safety, quality, finance, and satisfaction or engagement. I think I mentioned that, at least in my experience, my reading, engagement is a more powerful measure than satisfaction. I might be satisfied that I get a nickel off a gallon of gas at Joe's pump yesterday or last week. But if Sue's gas station has a dime off next week, I'm going to Sue. So I'm immediately satisfied or gratified, I even use that term, but I'm not engaged. I'm just going to whoever's the lowest price per gallon. And that's a real live example from yesterday's Philip. So let's take a look at each of these. Again, they're not mutually exclusive. And as a matter of fact, virtually every initiative or change initiative will impact more than just one. So as we look at safety, this is not a complete list, but I think when we look at individuals with whom we want to engage, we better put patients at the top of the list. And I know we do, but sometimes we don't. We always say we're there for the patient, but perhaps our staffing model or the devices that we use or the schedules that we use, sometimes they may be more focused on us than the patient. So let's think about, let's always keep them first. In my world, I put them at the top of every list, and not every project involves patients or family members, but certainly it forces me to say, what would this mean to the patients? Without them, there is no us. I mentioned families because in a lot of situations, particularly elderly individuals, that may not have a spouse or significant other. There could be another family member that provides support for them. Could be a daughter, a cousin, whomever it might be. We need to identify them and say, how can we keep them safe? Other caregivers, whether it be home health or Meals on Wheels or whatever. And certainly we want to make sure that our therapists, us, our clinicians, are safe to the extent that we can. And I just want to throw this out. And a lecture for another day is, there was a lot of sort of tsunami change in practice from nebulizers to inhalers. And I talk to manager pretty much every day in my day job. And I heard from dozens and dozens, hey, what do you think we should do? We're using nebs. They are not as safe as a meter dose inhaler or an MDI SMI. And I said, where'd you get that from? What emanates from that device is sterile, but it would be. We take it out of a vial or a bullet and squirt it in the nebulizer. The difference between fugitive aerosols, bioaerosols, and medication aerosols, a topic for another day, but think about how we can improve the safety of our respiratory therapists. Now, here's some examples. And actually, I'd offer you to put in the Q&A some thoughts as we go through each of these different domains. What do you measure in your department? So let's start at the top, missed or late treatments. When I was a student, and a couple years after that as staff therapist, we were required to put a note that we missed a treatment in total, or we were late outside of a 30-minute window either way. And I remember the discussion in the break room when the boss wasn't listening, to be blunt, saying, if we write this down, are we going to get in trouble? If we write that we missed it, and is someone going to think I'm not a very good therapist or a student earlier on? If I give a treatment 35 minutes after the top of the hour, and this is 7-11-3-7 QIDs at our hospital, am I going to get in trouble? And I'm here to tell you that that discussion would have been very different had it been in front of the department head. So the question I ask, and again, you don't have to identify your hospital here. Are you required to document missed or late treatments? If no, just put no in the Q&A. If yes, what happens with that information? So if we just take a minute now and I'll go through these, and if you could add that in the Q&A, that'd be very helpful. We'll use that for our panel discussion. The other aspect of that is, does it matter? Treatments do it at 7-11-3-7. Well, not everybody gets 7-11-3-7, but does it matter if it's an hour late? Does it matter if it's 2 hours late? Well, what kind of medication are we using? What is the half-life of that medication? Does it matter? What happens to patients in X-ray and you can't get to them? Do you document that differently? So if you wouldn't mind, just put your notes. Again, these are not shared outside of our group here today. Successful first attempt intubations. I remember an example where someone said, we need respiratory therapy to intubate after hours when anesthesia drops down, their staffing. Great, we can do that. What's the process by which we will be trained, competency tested, and then rechecked? That's really important. It wasn't then, it shouldn't be now. Do one, see one, teach one. But how would you look at the safety? And one of the ways could be, how many times you intubate first time now? Or blood gas for that matter, first stick blood gas. Third one was one where respiratory therapists were really slammed and had difficulty getting down the ED in time, according to the medical director. When I say slammed and overworked, understaffed, I'm talking about the 1980s and 1990s, not now. So not much has changed from those days. And the medical director and ED said, look, I understand you guys are slammed. Can you teach the nurses to draw blood gas? Hey, yeah, we can. We were all trained to do it. What mechanism do you have in place to see, did we train them properly? Did they do it properly? And the metric that we chose was examining whether there's a hematoma. And I think we used 24 and 48 hours after arterial puncture. And as we saw no change in hematomas from RTs to RNs, then you could say, hey, everyone can draw blood gas. Safe and effective staffing model. Al actually talked about this. I was pleased to be volunteer to be the project lead for the AERC Safe and Effective Staffing Guide, and I continue in that role, at least for the next couple of years. And in that guide, it says, this is what's important. We need to make sure that the number one thing on our list, number one priority, is safe patient care. And how do we do that? We need enough of us. Again, a lecture for another day on how we achieve that. But I'll suggest that we need to be more creative than ever in how we, on our staffing plans or staffing models, so we can flex more easily to change in patient demand. Percent of bronchopulmonary hygiene treatments delivered per protocol, and I would say versus directed physician order. And I talked a little bit about this yesterday. VAP rates, VAC, VAE, certainly we do as a team. And the last one, RT's lost days secondary to illness or injury. I don't know of anybody that tracks this. I think this is important, not just because of the pandemic, but we need to understand what is it that is within our control, what might not be within our control to keep all of you safe. If we can't keep therapists safe, we certainly can't deliver quality care. Last evening, I put this slide in this deck from my lecture yesterday because I got a couple of emails last evening saying, what was that thing again? So I just want to spend a minute on this. The Risotto study was simply about who performs assessment for individuals, for patients leaving the hospital in supplemental oxygen. In my estimation, when I look at the professionals at the bottom, other than ERTs, social workers and others, DME company, that is impermissible, by the way, physicians, they are all fantastic in their scope of practice, in their sweet spot. None of them are trained and competency tested to assess patients and determine the best device. And I think Al and Terry both mentioned this about reimbursement being a factor. Back in the day, home oxygen was reimbursed at a very high rate. In fact, probably too high. And the good thing about that is if a patient needed portable or liquid rather than a concentrator, they could get it because the DME company could afford to do it. That's really difficult today. Great topic for another day, but how do we change our role as hospital-based therapists to work with LTACs and SNFs and DME and home health and telehealth? That, in my observation, particularly over the last 2 years, has really come to the forefront. The bottom line, as far as safety, if we're not doing it, it's my opinion, it's not being done by the best educated and competency tested person. And you can certainly quote me on that. So there are some examples from safety. Again, in the Q&A, any ideas you have on ways we might examine safety, whether it's therapists protecting patients and families and others, would be much appreciated. We'll take a look at those in the panel discussion at the end of the day. Let's move on to quality. If you Google quality, you will get a gazillion hits. What I like to do is to keep it simple. There's two types of measures in my very simplistic world. It's what we do to measure in the midst of a process, and then what is the long-term outcome. What some folks use, and I like these definitions or these words, a process measure or process outcome, a lot of folks call a lead measure. And I'll give you some examples of that coming up. The long-term outcome, and long-term is kind of maybe not the best word. Long-term could be a day, a week, a month, a year, a decade, but it's that ultimate outcome that we're looking at. Could it be readmission rates in 30 days? Yes. Could it be a readmission rate in 90 days? Yes. Could it be total number of admissions for kids with asthma in 1 year? The answer is yes. So long-term, I'd like us to think about using the term lag measure, meaning it lags behind. So let's look at some process or lead measures. Here's some examples. You put oxygen on a patient, their SpO2 goes up. You complete all the sections of the patient assessment tool documentation in your EMR per protocol, great. Do you use that assessment and adjust per protocol? And I'll open-end that to say that might be rhetorical. I've heard from a number of therapists that we don't have time to assess. We're under the gun. We're slammed just to get the treatments done. And that's not in the best interest. That's not quality care, at least as I was trained as a respiratory therapist. The fourth one I mentioned this yesterday is to look at the percent of patients who are eligible for pulmonary rehab that started, that's one measure, and also completed. And I mentioned the other factors, the social determinants of health, finances, transportation, language, literacy, or whatever. The last one is no-show rate for PFT labs. I posted this on AERC Connect probably a year before COVID. And I said, what is the benchmark? And dozens of people said, I don't know. What's the benchmark? Well, for me, the benchmark should be 0. And it's ideal. It may not ever be achievable, but every single individual that doesn't show up for their appointment should be contacted. And what is within our control, what is not? If they were sick, they shouldn't have come in, but they need to be rescheduled. Maybe they thought the neighbor could bring them to the lab, drive them to the appointment, but couldn't. What's within our control? What isn't? And I think I meant about oxygen administration. Anyone, and I mean anyone physically, can put a cannula on, turn the flow meter to 2 liters a minute. Sometimes that's plugged into air. We won't go there. Anyone can do that. That's a task that virtually anyone can do as healthcare folks that work in the hospital. But who is best prepared to manage an oxygen management protocol? It's rhetorical, and everyone should be typing in respiratory therapist. So it's not oxygen rounds, it's not doing setups and getting 4 minutes for the setup. It's making sure that the patient has the highest quality, and that is their initial SpO2, or if you draw an ABG. Now let's look at some examples of long-term or lag measures. As I noted in the previous slide, we can't assume that our interventions are the sole cause of the patient outcome. Hopefully positive, but could be negative as well. But we must align what we do in such a manner that it supports the overall plan. A lot of words there. Let's use some examples. Our pulmonary rehab, your PR program, how has it impacted hospital admission rates and ED, or in some cases, urgent care visits? Do you measure that? I'd suggest that's a phenomenal lag measure. Patients that go through pulmonary rehab, dozens and dozens of studies show are admitted to the hospital less, go to the ED less. When they are admitted, and most everyone's going to be admitted sooner or later, their time in the hospital is less. All those are safety and quality and engagement and financial value. When someone says, and I heard this 2 nights ago, we're going to close our pulmonary rehab program because it doesn't make money. I just said, I need to put my cell phone down, get a glass of water, and I'll come back. Who said that? Again, without identifying the organization, most certainly it was their finance person, said, we're not making money on pulmonary rehab, so I have to close the program down in 90 days or whatever. And I said, pull up a chair, we got to talk. We're actually on a Zoom call. And pulmonary rehab makes a little bit of money, but not a lot. That was never the reason for pulmonary rehab. It's to help people stay in their homes, help people become people and not become patients. That's the value. Does that have economic benefit? Yes. If those individuals are admitted to the hospital and within 30 days and it exceeds the target for readmission, your hospital will be penalized. I've seen penalties, and you can literally go to cms.gov and pull this up. Hospitals penalized over $100,000 to $372,000 for COPD, exceeding their COPD readmission target. Does pulmonary rehab make a little bit of money? Yep. Does pulmonary rehab have the potential to save a lot of money? Absolutely. So think about, when we measure things, what's the why? What's the what? And we're going to talk about how later. Patient return to ED after discharge from acute care hospital. So a COPD patient comes in, and you give them a breathing treatment or maybe a back-to-back, they leave. As they come back within that calendar day, a common misconception was about 5 years ago that CMS said you can't charge for that. That's never the case. You have to add a modifier. That 76 modifier is the number, just in case you wanted to know. And you can treat that patient again, and the hospital will get reimbursed. The question I have is, yes, we want to make sure we can get reimbursed where appropriate, but secondly, why did that individual come back to us? Did we not use an effective nebulizer? Did we not give them discharge instructions that they could understand? If the physician or extender ordered an inhaler, did they get a prescription for a valve holding chamber? If they did they purchase it? And one of the things that each of us can do, a project, is look at the orders. So all your patients, all the patients are discharged on an inhaler where a valve holding chamber is appropriate. When the medical record, was it ordered? That's step one. Two, did they get it? Takes time. You don't get productivity points. Don't get reimbursed for that. But that's how we provide quality. And if you're looking for some place to start, talk to your quality officer, chief nursing officer, chief medical officer. We owe it to our patients to provide high quality care. We need a couple of minutes to do it. And I'm talking 15 minutes. I'm not talking about an hour. Ventilator length of stay, ICU length of stay, total length of stay. If you look at ventilated patient mobility programs, they impact all of those. While I take a sip of water, in the Q&A, please enter if you're using a ventilated patient mobility program or mobility program, if you want to call it that. And if not, why not? Again, Al and Terry are the holders of this information, so it doesn't go beyond the chat. But I'm really interested. If you're doing that, fantastic. Have you seen any results? If you're not using a mobility program, what have been the barriers to that? Again, you have my email. If I can help you with this as a friend, I will certainly do so at no cost, so long as I'm virtual. If you want to fly me to your place, that's a different deal. But let's grab some phone time or Zoom time to talk about how we could work together. I could help you as a clinician and maybe help the department head or whatever. If needed, you know how to get a hold of me. And rapid response, we know phenomenal improvement in quality of life for RN, RT, rapid response teams, keeping people from going to ICU. So here's some examples. PFTs completed within 2 days of physician request. Physician says, I need a PFT done 30 days out. How do you measure your compliance? Write it down. Let the physician know. Last quarter, you ordered 40 PFTs. We had trouble with one. We had difficulty getting the patient in because of transportation, but all the rest we did within 2 days. What's that matter? It shows them that you care. I don't know anyone doing this. Honestly, I don't know any department that does this, gives that feedback to the person who ultimately signs our paycheck, kind of, sort of. RT adherence to the patient-focused protocols, making sure our services are aligned with evidence-based medicine. Again, I talked about this yesterday. Readmission rate by the individual MS or DRG, reintubations within 72 or 96 or whatever number used, and why the patient needed to be reintubated. Same with bounce backs to ICU, whether you look at 24, 48, 72, or 96 hours, it's a number, but is there some systemic reason that those patients are requiring reintubation or getting bounced back to ICU? And then we act upon it, that which is in our control. Just want to put another note out about the AERC. Al did a great job of talking about the value of AERC and AERC membership. They got our back. The AERC Apex Award is a 2-year cycle, and currently we're in it. And if you work in an acute care hospital or a post-acute or an education organization, you can apply for this Apex Award. It is akin to the Magnet Award in that very, very, very few hospitals achieve this very high distinction. Just an example, when I talk about showing the evidence, this is what leaders want to see. Great, you say it so, I want to see the facts. So utilizing the highest level of evidence that we have, this is a peer-reviewed journal. Actually, no, I don't read it regularly. I use a search service to find articles such as this. And I mentioned it yesterday, look at the positive outcomes that are there, merely because individuals were provided the opportunity to go to pulmonary rehab. Finance. Can't do without them. In my experience, there are three categories that finance looks at: your direct and indirect service cost, cost efficiency, and cost avoidance. I'm here to tell you, my experience is the number one topic there, direct and indirect cost, is what comes out on our monthly responsibility reports or our cost reports or whatever. What I don't see enough of is looking at cost efficiency and cost avoidance. We've got to do it. Finance isn't going to do it for us. So let's look at each of these individually. When we look at direct and indirect service costs, there's really four costs that's part of that. The first is disposables, cannula, circuit, medication, etc. Our reusables, example flow meter. Capital equipment's number three, and the fourth is labor. Typically, labor is 50 to 65% of the operational cost of a hospital. And I think that's a number, again, it could be a little bit different in your organization. It might be 50 or 60 or 65 or whatever, but it's the majority. There is no hospital or health system that I've seen, that I've done consulting work in, where labor isn't the majority of the operating costs. We need to think about that. As we look at changing a service, a device, a medication, a piece of capital equipment, or a clinical ladder, what is the impact on labor? The direct labor is the RT time at the bedside. The indirect is salary and benefits. Benefits. The other thing we need to think about, administrative and support time, because in a 12-hour shift, you may do 10 and a half hours of direct patient care. That other hour and a half or 2 hours, it's not that you're goofing off. You're stocking shelves, you're doing inventory, you're setting up vents or tearing down vents, or going to break, if you get a break, going to lunch, giving a report. All those other costs are not typically examined when we look at productivity. And that's just absolutely wrong. Please quote me on that. We've got to look at the cost of providing patient care. And we can't have a productivity target that says, you, the therapist, you got to be at the bedside 12 hours in a shift. That's just nonsense, just nonsense. The other thing is, when we look at this, we've got to look at the outcome of that purchase price. You buy a new car, why? Because it's ultimately going to be better than your current car. You got a 30-year-old car, it maybe burns some oil, it doesn't get the good mileage, but you don't have a monthly payment. You buy a new one, you better get something more for your value, better economy, better for the environment, looks cool, smells cool. All of those outcome measures are in your mind when you're thinking about a car or refrigerator or bicycle for that matter. We need to think about that in our day jobs, and a lot of times we don't. So let's move on to cost efficiency. The cost efficiency of a service addresses how efficient that service is delivered in terms of how, going back to labor, time efficient we are as RTs. Now, yes, there's other things consumed. We have albuterol, we've got normal saline. Those are pennies on the dollar compared to labor. Let me give you two examples. You have two bronchodilators. The one costs X per dose. The other one is 2X. But maybe the 2X, the twice as expensive upfront bronchodilator, lasts 4 times longer. Which is the better medication? The one that costs $1, the one that costs $2, the one that lasts for 2 hours, the one that lasts for 4 hours, or 6 hours, or 8 hours. So think about that. When we buy something, whether it's a medication, a nebulizer, a cannula, a ventilator, what we pay up front is merely what we pay up front. That's a purchase price. What do we get for that? Again, I'm a car guy and a bike guy and a hiking guy and a fishing guy. If I'm buying something new, I want something better in the long run. And in terms of finance, the finance departments want to see what are you saving in the long run. The second, excuse me, sip of water time. Second example is you have two nebulizers. One is more expensive to buy up front, costs $1 more than the other one, but it provides double the percent of albuterol, as an example, in the 2 to 5 micron range. So let's think you got a $3 neb, $4 neb. One has twice the medication. What is the value over the lifetime of that? Meaning, I shouldn't say lifetime, but when the patient's in the hospital. Might you find efficiencies that are hidden within the cost? So when we look at the purchase price, that's the purchase price. That's all it is. We've got to say, what are we getting out of that? Meaning, what's the patient getting out of it in most of the cases? Or what are we getting as a therapist? So we need to think constantly about the value of that for the patient, the therapist, the department, and the organization. Let's move to cost avoidance. I promise you that when I've served in a budget committee, this comes up so infrequently. If we buy this, we're going to avoid this. Again, I go back to the car. If you've got a 30-year-old car, the chances of needing engine work or suspension work or muffler work or whatever is likely much higher. Now, you may decide to keep that car, and I'm one of those people. I may say, well, I may have to put a new muffler on next year. That's $1,000, but it costs me $30,000 for a new car. Now, I don't have a new car. I just have an old car with a new muffler. But there's a cost avoidance. It might be I don't have the money to buy a new car. Indeed, I don't at the moment. But even if I did, is it better to utilize what you have currently, or is it better to purchase a better nebulizer, heated wire circuit, or ventilator because avoiding cost, downtime in terms of ventilators? So again, what we need to think about is the value of the intervention, the medication, the device, the capital device, capital equipment. What's the upfront cost? What's the indirect service cost? Preventive maintenance, upgradability of circuit boards and that sort of thing with ventilators. What is the efficiency of that device? Looking back in the day when I was early in my career, we didn't have IMV. We had to build our own IMV tubing. Now it's a button or a knob. Think about the efficiency of that equipment. And is it better for the patient? If so, how do you have the evidence? Is it more efficient for the patient? Maybe it's not for the patient. Maybe it's more efficient for me as a therapist. What other costs could you avoid? Rick Ford, one of my best friends and mentor, in fact, he works with me and another individual on the AERC Safe and Effective Staffing Guide, said this years ago. And this was a meeting prior to the AERC Congress, probably 20 years ago, if not more. And one of the directors, about 150 directors in the room for this pre-Congress meeting, proudly said, our respiratory therapy productivity is 118%. Well, a number of us looked and said, you can't do 16 hours of work or 15 hours of work in a 12-hour shift. And it was that long ago. We didn't have 12s, we had 8s. I remember saying 118%, what's that? You do 12 hours of patient care in an 8-hour shift or 10 hours of patient care, whatever the math is. Rick stood up and said, I looked at your numbers. 20% of your services are not clinically validated. Therefore, your productivity is more like 80%, not 100%, as we convinced her to decrease her actual from 118 to 100%. It may not even be that. So think about what you're doing in terms of value, and think of what you're doing in terms of the time spent in non-validated services and procedures, because that is waste. And finance would love to hear that. In fact, they would love to hear you say it rather than them hiring a consultant to point that out. So here are some examples. We need to look at clinical productivity. If you're a staff therapist, if you're a manager, you're a team lead, you know it. This is a daily occurrence. We have to be productive or efficient. We could look at the percent overtime. Someone said to me, the benchmark should be 0. And I said, that's just nonsense. If you never use overtime, there's just something you need to look at. You might be overstaffed. A little bit of overtime used judiciously for FMLAs or, someone leaving the department abruptly, talking to manager this morning, he hadn't had anyone leave in 6 months. Now he got 3 resignations, all for good reasons at the same day. The cost of agency staff, we've talked about that. The labor cost per procedure hour, not labor cost per check mark that you did, but the labor cost per procedure hour. And then what have you done to reduce your expenses by eliminating non-value added procedures? I used this in another lecture, and I want to use it to illustrate. Sometimes money is saved by investing labor and finances in better devices. And what John Wilson and his group did is they went from an ineffective nebulizer to an effective nebulizer that cost more money. It cost significantly more money. They paid for that, and they banked all the rest because they put quality and safety and finance, not just the acquisition cost, but the value that you get for them. Here's a group. In fact, this is a pharmacist and a physician were the 2 authors for this. And they had done a great job in reducing their COPD unplanned 30-day readmission rate. Unplanned readmission rate. By, I think they went down like 18 to 12% or something like that. I called the one fellow, I talked to the pharmacist about this. And I said, I read this, I love this. Were you guys not satisfied with your phenomenal reduction? And he said, we're never satisfied. We got from a high mark to a fantastic mark. Target percent readmission rate, we weren't satisfied. So what we figured was, let's go ask the patients. They asked the patients and they said, we don't have the money. They're not filling their prescription. So checking a lead measure, did the physician order the MDI? Did they order the valve holding chamber? Yes and yes. That doesn't mean the patient got them. Doesn't mean they could afford them. It actually doesn't mean that they used them appropriately. So what we need to think about is what this group did is that whatever the patient was going home on, their maintenance medication, very expensive, no doubt about it. Whatever they were going home on, they gave it to them in the hospital. Again, can't charge for it. It's a DRG reimbursement system. But they gave it to them in the pilot and said, I wonder what will happen if we give it to them, we train them how to use it, will it impact unplanned 30-day readmissions? And it did. You can read the numbers. Not only 30-day, but 60 days. Do you know what the out-of-pocket cost is for these fabulous medications? I use one. It's fabulous. It's $200 out of pocket. Some folks don't have that. And as a result, they may get nothing, or they may get the device and not the valve holding chamber. And you know, as therapists, how little medication someone gets if they don't use the valve holding chamber. I mentioned mobility yesterday. Here's one of many references. This group mobilized patients. The tube came out quicker, got off the ventilator quicker, they're out of the ICU quicker, and it was phenomenal savings in money. Did they do it to save money? Absolutely. I'm sure they did, and talk with the authors. But they did it for better quality, better safety, better patient and family engagement. If you're looking for a good textbook, excuse me, sip of water. If you're looking for a great book on understanding value, I highly recommend this. No, I'm not part of the authors. One of the authors, if you scroll down to the bottom there, is Zach Phillips, registered respiratory therapist and master's in healthcare administration. He is one of the authors. It is worth a read. Get it from your library. You don't have to buy it. It is worth a read. It is a generic book, but then examples are given from the hospital perspective by a pharmacist. Actually, I think two pharmacists were on here. Zach's brother is one, and Zach himself is a respiratory therapist. So I highly recommend it. Let's move on to satisfaction and engagement. It's 347. Who should we look at? You don't even have to think. Patients, families, number one. What about nurses, physicians, us, administrators? I'm here to suggest that without a list, we may leave somebody off our engagement, our collaborators, to demonstrate our value and increase our visibility. So what are some examples we can look at? We can look at HCAHPS scores. This is required by the federal government for decades and decades, and it's patient satisfaction is the short name for it. I think there are 28 questions. There's not one in there that says, hey, how was your respiratory therapist? So the second point is, let's do our own. Let's ask patients, did we do the right thing? Did we explain the medication? Did we tell you what's coming next? Do you have any questions about it? Did we show you how to attach the valve holding chamber to your meter dose inhaler? Do you have the ability to purchase those? If not, let me contact a social worker. Same with outpatient services. I like to ask nurses, how are we doing? It's real easy. Back in the day, a 3x5 card, hand out each nursing station. Please fill out satisfaction, whatever our ranking score was, 1 to 5 or something like that. With it, put it in the box that we had folks in maintenance make for us. And the box is locked, doesn't have your name on. We will have a third party, human resources, pick those up, put them together, and give them to respiratory therapy team. So we didn't get to put the 3x5s in ourselves. We didn't get to look at them. And if there was anything in there that said, hey, Susan, great therapist, I hope you're recognizing that. Well, maybe I hadn't. Or Bob's okay, but Bob could learn a lot from Sue. That's the feedback that you get. So you give the results. When human resource gave the results to us, we gave the results to the nursing community, and we did the same thing with physicians. For ART keys, turnover rate. I was talking to director earlier this morning. Turnover rate has all but doubled during the pandemic, but it was bad then. Our turnover rate needs to be examined, not only a number, what's 12%, what's 18%, but why? In my opinion, if a therapist leaves, let's just say my hospital, to become a higher position, or if you think a department head's a higher position, or in some cases lower position, if I get a staff therapist who becomes a director down the road to the other hospital, man, that's party time. That I don't consider to be a negative turnover. If we have a gentleman or a young lady starting a family, and let's say a husband and wife are working together, and one of them needs to leave their employment to start their family, that's celebration time. Others may not look at that, but I don't think that's a negative. That's a very positive. And certainly employee satisfaction scores. Here's a great example. And I used another example similar to this same organization. And they looked at satisfaction pre and post implementing protocols. And this is one statement. 95% of the therapists utilizing protocols believe that they are now a respected member of the medical team, and that their opinions regarding patient care are now valued. If you pull up the article, you're going to see a very, very low number as to what they felt their value was prior to using protocols. It's painful to read it. It's over 10 years old. It's worth a read. Just go to aerc.org and search for that. You will be amazed how one seemingly simple thing, implementing protocols, improved what therapists thought about therapists. Powerful. So who? Clinicians, medical director, decision makers, and champions. The list can be much longer than this. I'll suggest that your medical director always needs to be number one. Always needs to be engaged, always needs to be involved. And if someone says, my medical director doesn't get paid enough, I think that's garbage. Not garbage, they don't get paid enough, but that's an excuse. How can you engage your medical director? A 5-minute cup of coffee, maybe a lunch, if we get those things anymore, to say, I really would like your feedback on this protocol. Can you help me understand from the physician standpoint whether this would work for you? 30 seconds, that's all it took, a couple of minutes. Decision makers and champions. Now, your medical director is not always going to be the champion. It may be infectious disease physician. I remember when we looked at common canister back in the late 1970s, one of the opponents of that was infectious disease, who felt that the common canister protocol would spread bugs from patient to patient. When we did a study and showed that it did not, he became our champion. So here's a list. I'm not going to go through them, but I will highlight when we most tend to look at acute care hospitalization. That's where 80% of us work. But I'm going to suggest we need to get outside the four walls and think about what is it that is most impactful for that person who's a patient today and a real live person tomorrow at home. What's most impactful for them to stay in their home where they want to? It may have nothing to do with a hospital stay. It may have a lot to do if we educated them, provided them the right equipment, made sure they did return demonstration, and made sure, working with the transitional care nurse or the social worker, that they could afford the pharmaceutical and that they actually got it. And they got the next month's dose. So measuring, did they get it? Did they use it going out the door is great. That's a lead measure. A lag measure is, did they fill the prescription after the first 30 days? And I know of very few organizations, hopefully a lot are doing this, but I know very few that are able to do this, look beyond those 30 days. It's important. Post-acute care providers, LTACs, skilled nursing, ALFs, DME, home health. Certainly that's an area where more and more people are spending more and more time outside the hospital. I forget the citation, but I read this a few years ago, that hospital care was 60%, somewhere it was the majority of Medicare expenditure, but it was only 5 to 8% of total days in a person's life. If we're only looking at 5 to 10%, we need to be looking at the 90%. Rapid response, again, can we do something in concert with our nurse colleagues? Absolutely. Here's a great study. Sue Herzig presented 12 years ago. Look what happened. It's a Photoshop. It's not a therapist and nurse necessarily. Get off the web. But what happened? Good things, safety, quality, and improved finance. A person who doesn't need to go to the ICU doesn't need to spend the money for the ICU. More importantly, they get to go home earlier and more likely they'll survive it. So how? My favorite radio station is WIIFM or WIIFT. What's in it for them? So for each of these individuals, how would they perceive your value? Different for finance than nursing, physician, quality assurance, performance improvement, compliance, legal. Think of the them and then write your value proposition in words that would resonate with them. We don't change the words. The words are the words. We provide safety and value and patient comfort and patient engagement, physician engagement, nurse satisfaction. We do those, but the order in which you create your delivery may, in my opinion, should be modified for the audience. So what are the components? My estimation, value proposition. What are the goals? How are you going to measure the goals? What are your audiences? That's the WIIFT. And what methodology will you utilize? So in summary, my experience, my recommendation, start with the why. If there's no why, do something else. Once the why is there, we need to improve the safety for our patients coming to pulmonary rehab. If they park a block away and have to cross 2 red lights, that's not safety. We need to improve the why, get them better parking. The what? The new process or the revised process that you are going to propose, that's the what. Who's involved directly, who's involved indirectly, and the how is the process, the goals, the metrics, the communication for each of those audiences. And with that, I'll conclude this presentation and thank you for being a respiratory therapist and a happy respiratory therapy week next week. Thank you.